I'm going to focus on is the role of the community psychiatric nurse in care of patients living with dementia in the community, which is what I'm doing at present. So, what do I mean by in the community? So that's people living home alone, home with someone, or in a residential aged care facility. So, my existing role, what do I do at the minute? And some of my colleagues from the community are here today, and you can tell me whether I do this or not. So part of my role is level of care assessments. So where do people fit into the spectrum of residential aged care, which exists in 4 levels: rest home, hospital level, dementia rest home, and psychogeriatric hospital or high dependency units. And so my role is trying to ascertain where that person's needs will best be met within that spectrum of care. Actual hands-on nursing. So that might be anxiety management with people. It might be monitoring how treatment recommendations are working, whether that be medication or non-pharmacological interventions. I'm also there as a resource for primary care and colleagues in aged care facilities. Family and carer support and education. And my role also has a teaching aspect, so both within further education facilities like Whitireia and within the healthcare system and aged care. So some of the issues which we've touched on in Ian's session earlier are everything we hear about at the minute warns us about these demographic changes, this so-called silver tsunami that's coming. My generation, the baby boomers, the 1945, 1965 generation, we're all getting older now. People are starting to get referred. And with that come the change in expectations. People have Googled things before they come and see you now, or they go home and look it up afterwards. And this does impact on how we work. I've got one GP colleague who now texts me, and it quite took me by surprise when a carer started texting me recently. I'm not used to people being up with technology. So there's change in expectations about what services should provide. And we heard from Ian about some of the legal issues. So my team is also there as a resource for wider services around some of these legal issues. And when we first meet someone, one of the first questions we will ask them is, have they got their enduring power of attorney in place? If not, get onto it. We also use the PHARMAC, and recently on our ward, which is a 12-bed assessment ward out at Kenneperu Hospital, we had 3 patients waiting for decisions from the family court, which out of 12 beds is a lot of beds to have out of commission just waiting till we can move people on. So yes, it does have implications if people haven't named their EPOA. And occasionally, not often in our service, but occasionally we do use the Mental Health Act. And recently we admitted a lady who had been living home alone with cognitive impairment, and things had incrementally got worse over time. And it had reached a point where her main support decided, no, can't do this anymore. And the lady had no awareness of her limitations and couldn't make a decision to accept more care. And we did need to admit her under the Mental Health Act. And so my role in that was in supporting the GP and the practice nurse and the niece to make the applications under the Act, because that particular GP practice weren't using the Mental Health Act very often and weren't up on the forms. And so my role was as a support. So, as I said, I work with the psychogeriatric team, and we all hate that name. And earlier this year, after much debate within the team, we did decide to change it to the Older Adult Specialist Interdisciplinary Service, which, as well as having the nice acronym Oasis, which we really liked, we felt it was vague enough not to scare people before they met us, which of course psychogeriatrics does. Nobody wants to be described as psycho or geriatric. But unfortunately, another service had got first dibs on the name Oasis, so we were told we had to stick with psychogeriatrics. So who are our client group? So people with behavioural and psychological symptoms of dementia of any age. People with an unclear or complicated diagnosis where it isn't straightforward, where could this be depression? Has this person got a delirium? People over 65 with a recent onset functional illness, so depression and anxiety. Or people who sometimes get called the graduates, people with an enduring mental health problem who are now over 65 and now have comorbidities of old age, so that their needs are now better met in older person services. If they're a young 67-year-old with enduring mental health problems, they'd stay with their community mental health team. So how do people access our service? So referral either comes through the Care Coordination Centre, which is the one point of entry for DSS-funded services, or PHARMAC, which is the one point entry for mental health services. So that's the distinction between the two. And a little plea, if people are making referrals, please be specific about presenting problems and your expectations. I do sometimes still get lovely letters saying, please see this delightful lady with dementia. Okay. So tell us what you want. So this is one of my personal soapboxes. How can we develop the nursing role? And I saw on the attendance list that we've got nurse practitioner and interns in the audience, and I'd love to hear from you guys. These are the areas that I think nursing could develop its input into the care of people with dementia. And by nursing, I mean me. This is a selfish self-promotion here. What I would like to do is to provide regular support for the residential aged care facilities. At the moment, our team consists of one psychogeriatrician, one nurse, a bit of an OT and a bit of a social worker, and a vacant psychologist post. So we're very thin on the ground, and I think there's capacity. I think we could do a lot more. I would like to run nurse-led clinics in the facilities so that facilities would know they were getting some regular specialist support. At the minute, it's ad hoc, when I can pop in somewhere or on request. And to support collaborative care as well. The people we work with often can't participate in shared decision making, or their ability to do so is limited. And we need to work with who their legal decision makers are, their enduring power of attorney, their welfare guardian, the people in the residential aged care facility who are looking after them day to day. And I think as a psychogeriatric team, we can support that. And help with non-pharmacological interventions. Now, I know we're at a PHARMAC day here, but part of the appropriate use of medication is about getting the appropriate non-pharmacological supports around someone. And we can help with advice and guidance around that. And there's also the evolving role of the nurse in medicines management. More and more of us are doing the nurse prescribing papers now and progressing into posts that allow us to use those skills. nowadays there's lots of pathways and guidelines about optimal treatment of conditions that might recommend 1, 2 medications for each condition. The thing with our client group, they've often got multiple comorbidities. So if they're on a couple of meds for their blood pressure and a couple of meds for their arthritis and something for their dementia, and so we've got to weigh up optimal treatment of comorbidities against the risks that go with polypharmacy. And that's not always an easy tension to resolve. We hear in the media often stories about these hordes of elderly people in residential aged care with undiagnosed and untreated depression, and then we hear about people on 15 medications, and so it's a tension that we need to try and find a way through. Review of psychotropic medication. People have often been on things for a long time, and people can be reluctant to tinker with things. So as a specialist team, we would look to provide support for safe, effective and appropriate prescribing. And again, trying to balance that treatment benefit and treatment risk. And this is one of my personal biggies, deprescribing of antipsychotics in dementia care, which is one of the drivers that encouraged me to do my nurse prescribing papers, because often the antipsychotics will be prescribed appropriately, but then they're never reviewed. And behaviours ebb and flow with the progression of dementia. And the medications aren't always reviewed in line with that. And I think we would have a valuable role through the nurse-led clinics in ensuring that that regular review happens. Review might not necessarily mean taking somebody off it, but it means at least asking the questions of, is it an appropriate time to review those medications? And having worked in residential aged care facility, if you're the only RN on duty and somebody's calm and settled, you can be very reluctant to ask the doctor to rock the boat by taking them off a medication. And I totally understand that. And if you've got a bit of specialist support and you know it's going to get reviewed next week, it might just lessen the anxiety around trial and reduction of medications. Now, before everybody jumps on me and says we should be doing this anyway, absolutely we should, but I think it's something that we don't do as much as we should do, to report adverse drug events and encourage our colleagues to do that. And also providing education for colleagues in residential aged care facilities. Now, I do this now, but I think we could do it on a more formalised basis. The sessions I get asked for most are BPSD. How do we manage behavioural and psychological symptoms of dementia? And one of my other personal soapboxes, delirium, which I think is underdiagnosed, and often in the general hospital as well, people will pitch up in hospital and then we hear, oh, well, she's got dementia. Well, yes, but she could dress herself last week. If there's been a sudden change, something's going on for this person. So I think we don't always pick up on delirium as well as we should. Education around psychotropic meds. These are serious drugs we're giving people, and people should have an understanding of what it is they're given. And sessions around mental health and ageing. And one of the big roles I would like to develop is as that resource for primary care, particularly with the rollout of the dementia pathway, which is happening now. The education around that should be happening any second. We've spent the last year localising the dementia pathway, and the Pathways Project are just seeking feedback on that now. But the big drive of that project is about shifting diagnosis and management of uncomplicated dementia, whatever that is, into primary care. And I think a lot of GPs and practice nurses do feel they need specialist support to take on that role. It is time intensive, talking to people, getting the collateral information. And I think practice nurses will find that task coming their way. So I see that we could be a valuable support in the rollout of that. And as we talked about, the demographic changes and the impact that's going to have on primary care. So what will it look like? In residential aged care facilities, that the facility staff will be the main carers, with primary care being the lead care agency, and hopefully the NP providing the specialist support via that little circle at the side. And I included this because my daughter has just taught me how to include Venn diagrams in a PowerPoint presentation. So in this advanced nursing role, why should I have any credibility? What preparation have I had for this? So I did my registered mental nurse training in the UK. It's 3 years hospital-based training. I then did 3 years part-time study to get my diploma in nursing. Another year to do my CPN certificate. 2 years part-time to do my bachelor's degree. 4 years part-time to do my master's degree because I lazily took a year out to have the aforementioned daughter. And at that point I came to New Zealand and promptly found I had taken totally the wrong options in my master's if I ever wanted to be a nurse practitioner. So I had to pick up 5 extra papers, and the clinical assessment paper at Massey University, I think its correct title is Advanced Assessment and Clinical Reasoning, the paper run by Alison Pirrett. If any nursing colleagues get the chance to do it, do that paper. It is fabulous. I learned so much and came out of every lesson with eyes like saucers, mortified that anybody had let me be a nurse without knowing that stuff. So highly recommended. And then I did the 3 nurse prescribing papers up at Auckland. And another tip for any nursing colleagues that a nurse practitioner colleague, Elaine Byrne, told me, and I would never have thought of, if you do postgrad education, talk to nursing council about it, because when I had that conversation with them, they said, oh, okay, right, fill in this form and send us the required fee, which I did, and then they took the mental health only restriction off my practice certificate. So after 30 years, I am finally a proper nurse. Although part of me still thinks that it was the $200 fee that swung the decision. But to be an MP, you need 4 years minimum experience in your specialist area. Excuse me. And then you need to develop a business case, which is the stage we're at now. And with the 3 DHB project that's going on, I'm kind of hoping it will slip across someone's desk and get stamped without them reading it too much, although it may sit in someone's in tray for the next year. So I'm hoping to gain approval for an MP candidate stroke intern position. And then, as any interns will know, there's just the small matter of presenting the portfolio to Nursing Council. But this advanced nursing role does involve a paradigm shift. We're changing from this old-fashioned doctor's handmaiden role of nursing to being autonomous practitioners. So from hiding behind the white coat to having our own name on the office door. But personally, I've found that change of mindset quite hard. When I was trained, we had the 4 Ds drilled into us. Drugs and diagnoses are the domain of doctors. And don't go there. But one of the key requirements of nurse practitioner is that you do consider differential diagnoses. We are supposed to be thinking of that now. And despite all the postgrad education I've done, and despite watching all the reruns of House, I still find it really hard to do. So some of the resources that I just want to share with you because I've found useful recently. Now, I'm sure a lot of you will have heard of or done the MOOC, which I've just completed myself, because when I heard about it, I wasn't quite sure who to recommend it to, and I thought the easiest way to assess that is to do the course myself. So I did. So it's an 18-week free online course, and my feeling is it's suitable for everybody, from family carers to healthcare workers. It reminded me of things that I'd long since forgotten. Which lobe of your brain does what? I haven't thought about that for years.
What does MOOC stand for?
Massive open online course. Or some combination of those words. But yes, absolutely worthwhile doing. And it's about 3 hours a week for 18 weeks. And something I've only recently discovered is the Future Learn resource. And again, free online courses. And for anybody who's trying to get their education hours up for their portfolio, these courses are great. Future Learn isn't healthcare specific. They do courses on anything and everything. The two I can speak about personally, the medications adherence course, which is run through one of the London teaching hospitals, and it is just a 6-week, 1 hour a week course, but quite useful. And the one I've just completed is the Science of Medicines course, which the chemistry was at the top end of what I could cope with. But the advantage of these courses is the cohort of people you do it with. The chat forums are extremely useful, and I managed to link up with an 81-year-old retired industrial chemist in the UK who got me through the chemistry bits of the course. And again, that was a 6-week course. They're free unless you want the flash certificate at the end, which you do pay for, but you're not obliged to do that, which I certainly didn't. And a tool I found really useful recently is the NZ formulary, and the little app on your phone is great. The interactions tool is brilliant. Just put the meds in and it flicks up the interactions for you. So if anyone hasn't got the little app yet, get it, it's great. And these are just some documents about antipsychotics in dementia, and which Ian was involved with, I know. And they're available online. And that looks different now because it's just been updated, but it's still. So now I need some questions from you. Can I abuse my position up here first and just ask the interns and the MPs in the audience, does how I see my role evolving fit with what you're finding in reality?
Absolutely. I'm the nurse practitioner in the group.
Right.
Pretty much where you see yourself going is where I'm at.
Right. So are you running nurse-led?
I work on an independent basis. I'm attached to an assessment treatment and rehab unit.
Right.
So do your residential aged care facilities and and it's multidisciplinary technologies.
Right, and are you finding they're using you as that resource a lot?
I think so. Yeah.
Right. Oh, that's good to hear.
Be your hardest part.
Absolutely it was. It was a lot of blood, sweat and tears went into it. And I have to acknowledge other MP colleagues who were very generous in sharing the work they've done so Anna Reid and Sylvia Meyer have shared their work. So any questions about any of that?
Does anybody know, my practice, I'm a GP and my practice is to, if somebody's got dementia, I will usually just refer them to the geriatric unit, manage them as well as we can in the community, but sometimes they just need that extra input. My normal practice would be to refer them to the geriatric health unit for a clinic appointment and activate it that way. Is that the best way to be doing it? Does anybody know the Auckland system? Is that the best way to be doing it, or do we have nurse practitioners that we would actually be getting better value from because it can all be done in the community? Does anybody know the Auckland scene?
If you're in Waitomato, you're in Strike Gold. They have a very, very good geriatric service.
But you access it through a geriatric referral through the company?
I'm not sure actually. Does anybody know? Yeah, you are. Yes.
I'm from Waitanata, and Auckland has two nurse practitioners, gerontology nurse practitioners, who I understand work quite closely with the geriatricians, who also have outpatient clinics.
Okay, but it would be activated through a geriatric referral. Yeah, okay. Just a comment, if New Zealand formulary doesn't answer your question, 0800 drug info are brilliant for those really ones. So take that one away. They encourage us to use New Zealand formulary first line, but there are some things that this doesn't answer. So 0800 drug info, they are brilliant. Very good.
Thank you for sharing.
Kia ora, Lesley. Thank you for your talk and probably in line with that commentary really, and certainly endorse your overarching premise of deprescribing when drugs that carry significant burden are being used, perhaps not clinically indicated, or when optimal health outcomes aren't being achieved by patients. And certainly that's the realm of PHARMAC too, so your comment around that, that's absolutely what PHARMAC are about also. But just a bit of a plug really for the Health Quality Safety Commission and CARM, the Centre for Adverse Reaction Monitoring, and the new MIRP pilot that they've got going, so the medication error reporting pilot that's happening. It's way easier to log any kind of adverse event or error or anything that you'll see now, potential error, and it's all online, way easier to do, and they're really hoping to collate more information from that. Anybody, certainly asking for that, because we are, as you rightly indicated, very bad at doing this. So yeah, have a look online, guys, under the CARM.
Yes, I do think there's scope for all of us to do that better.
Is that linked into the practice formats that we have, like MedTech and things like that?
Not currently, no. It's only recently been launched.
Okay, so we need to go onto the internet and do it that way.
Yes, yeah, the internet would be great. Thank you.
Yeah, I'm sure it doesn't come up that you can directly connect to it under Connect My Care or Manage My Health, one of those popped out.
Any other comments or questions?
I'm a bit biased now because Lesley is my kind of link nurse and the dementia unit that I manage. But it's just kind of to back Lesley up and all you lovely nurses and how your role could be developed. I kind of mentioned it a little bit in my presentation later, but I think for rest home, for aged care facilities to have access to that service, that nurse practitioner role, is so beneficial. We would, I would be more than happy. I do ring Lesley up when I need advice, but Lesley's pulled in so many directions. You always get back to me, but it would be just fun to you do. But I think, I manage the dementia unit, but the other areas, the rest home level care, the hospital level care, things happen, people progress, things change. And to be able to tap into that resource to try and manage people in their own home rather than having to go to hospital or whatever is just fabulous. So I really hope the DHB kind of go with that.
Lisa made a comment to me recently that I hadn't thought of, I have to admit, that she saw the advanced nursing role actually having more benefit and impact in the non-specialist areas of care, where I tended to think of my input fitting into the dementia units, where actually the vast majority of people with dementia are in mainstream services, they're not in specialist services. So my input would be most useful into those mainstream areas of care, supporting units like Lynn's. So yeah.